Peripartum cardiomyopathy is a heart muscle disease which occurs in the last month of pregnancy or within 5 months of delivery. Left ventricle, the lower left chamber of the heart, becomes very weak and enlarged. As the left ventricle is not able to pump out blood well, it dams up in the left upper chamber and the lungs. This leads to collection of fluid within the lungs known as pulmonary edema, which causes severe breathlessness. Sometimes the blood pressure also falls as the heart is unable to pump out blood well. The risk of peripartum cardiomyopathy increases with age of the person. It can occur in about 1 in 4,000 pregnancies and contributes to 4% of all heart muscle diseases. The disease can be diagnosed by echocardiogram, the ultrasound study of the heart. Sometimes the individuals may become very sick and can even die. There is a chance of recurrence during future pregnancies, and it is better to avoid further pregnancies. Occasionally, some who have recovered very well have undergone next pregnancy safely. If there is any persistent defect in the pumping function of the left ventricle, future pregnancies are absolutely risky. A genetic background has been noted in at least some of the cases of peripartum cardiomyopathy. This is more likely in those cases which do not recover as usual after delivery. Relatives of some of those who had not recovered well had undiagnosed dilated cardiomyopathy. Dilated cardiomyopathy is a heart muscle disease which is similar to peripartum cardiomyopathy but unrelated to pregnancy. Genetic studies showed mutations in gene encoding for heart muscle protein in some of them. A link between cancer and peripartum cardiomyopathy has been suggested. In a study from Germany, some of the patients who had peripartum cardiomyopathy had cancer either before or after peripartum cardiomyopathy was detected. Some of them had cancer medications which are known to weaken the heart muscle. Recovery rate from peripartum cardiomyopathy was noted to be lower in those who had cancer than in those who did not have cancer. The study authors suggested that it could be due to genetic factors. They suggested screening for heart failure during pregnancy in those who had cancer and screening for cancer in those who had peripartum cardiomyopathy. Subsequent pregnancies are discouraged in patients who have reduced left ventricular ejection fraction after an episode of peripartum cardiomyopathy as per recommendations, though it may sometimes be considered in those who have fully recovered. A retrospective review from the US checked 137 patients with peripartum cardiomyopathy in a registry. Of these, 45 patients with subsequent pregnancies with a mean age of 27 years were included in a study. 80% of the women were of African American descent and 75.6% were from low socioeconomic background. Two-thirds of them had recovered from the initial episode as defined by a left ventricular ejection fraction 50% or more. 40% of patients had 2 or more subsequent pregnancies. 3 or more subsequent pregnancies were noted in 6.7% of those who had not recovered and 26.7% of those who had recovered. Subsequent pregnancy was associated with mean decrease in LVEF from 45% to 41%. P is equal to 0.009. Adverse outcomes at 5 years were significantly higher in those who had not recovered compared to those who had recovered LVEF, 53.3% versus 20%, driven by a relapse of peripartum cardiomyopathy. 5-year all-cause mortality was 13.33% in those who had not recovered LVEF, while it was 3.3% in those who had recovered. At a median follow-up of 8 years, adverse outcomes and all-cause mortality were similar in both groups, 53.3% versus 33.3%, P is equal to 0.20, and 20% versus 20%. Authors concluded that subsequent pregnancies in women with peripartum cardiomyopathy were associated with adverse events. Normalization of LVEF does not guarantee a favorable outcome in subsequent pregnancies. An accompanying editorial highlighted the 20% mortality in both those who have recovered and in those who have not recovered initially at 8 years. An important limitation regarding generalization of the results was also pointed out. This study was from a single center where mortality in women with peripartum cardiomyopathy was higher than in other studies from the United States. Most of the patients were African American and of low socioeconomic status. Earlier studies have clearly demonstrated a different phenotypic presentation and outcome in African American women with peripartum cardiomyopathy compared to non-African American women. African American women had been shown to be diagnosed later, present lower LVEF, larger LV volume, and more severe heart failure symptoms. The rate of recovery was lower and time for recovery markedly longer in that patient group.